Shall we start? Assalamu alaikum. Good afternoon, everyone. Welcome to session 2. And in session 2, we'll be having 2 satellite symposium. The first one will be by Dr. Mervat Mahrous. Dr. Mervat is a consultant of adult medical oncology at Prince Sultan Medical City. Dr. Mervat is a well-known speaker in the field of lung cancer. She is our friend and colleague, and she's going to talk about unique concept in treating stage 4 non-small cell lung cancer. In the first setting, Dr. Mervat will talk mainly about Checkmate 9LA. Dr. Mervat, please.
Thank you very much, Dr. Nafisa, for introducing me, and thank you BMS for inviting me for this slide symposium. I would like to thank the organizing committee of the Thoracic Oncology meeting, and I would like to thank Professor Qattan and Dr. Ashfaq and Dr. Nafisa again for inviting me as well. I will give a talk which is a unique concept in treating first-line non-small cell lung cancer, Checkmate 9LA. And this study actually has a lot of interest last year when it's presented in ASCO 2020, and even there was an update in ESMO regarding the quality of life, and this year in ASCO it was updated regarding the 2 years quality of life. And we have to know that the dual IO blockade, it's one of the great interests for the whole lung cancer community. So when we look at the lung cancer burden all over the world, we'll find that lung cancer is still presenting one of the leading cause of death, and specifically for men, 24% of all men, comparable to 14% in female. And this means that we need a lot of work and also a lot of medications to help in this part. The issue that when we look at the non-small cell lung cancer, we found that about 80 to 85% of lung cancer is a non-small cell lung cancer, comparable to about 15 to 20% of a small cell. And majority of the pathology, and I'm sorry that the pie and the figures, it's not apparent here in the slide. About 60% of adenocarcinoma and 80% of squamous are associated with known mutation. When we look at the survival for the patient, we know that about 55% of the patients, when they have only 16% of them, they are presented with localized disease. However, the majority of the patients, which is even 57% of the population, they have a distant metastasis, and this gives us a survival about 5%. And we'll come to the main point that the staging is correlated to the survival of the patient and outcome. And this is why in non-small cell lung cancer patient in the metastatic, which is the majority of them, the introduction of immune therapy, and when we have the introduction of the target therapy before the immune therapy, it was changing the era. When we look at this part, we found that the targetable driver mutation, when you look at the squamous, and the squamous about 15%, they can even have a driver mutation. We know that the squamous, they are specifically for the patient with non-smoker, or the patient have mixed histology, they can have a driver mutation as well. But mostly it's the adenocarcinoma and large cell, and you can see here the mostly the driver mutation as adenocarcinoma and large cell. You can find it clearly in this part. The improved survival is a challenging in some advanced cancer, and you can see that the 5-year survival for lung cancer, it's almost 4 months. and 4% for this patient, and for the RCC patient 12%, and in the melanoma about 16%, and we consider it a dismal one. And this is why we need, as we pointed out, I don't know why all the figures, it's not apparent, but we can, I'm sorry for that, but of course you are familiar with the T-cell checkpoint inhibitor and the stimulator as well. And in the upper part of the slide, you can see the activation, and this is the element regarding the OX40 and the PD-L1 and the CTL4 as well. And this is for inhibition. When we are talking two parts from the inhibitory part, which is the CTL4 and PD-L1, this will be synergistic effect for the blockade of agents for these patients. When we look at the nivolumab as a mechanism of action, we will find that the nivolumab, it's mainly blocking the PD-1 receptor, and this is why it's one of the main items regarding the inhibitory mechanism in the IO therapy. And the ipilimumab, we do have the CTL4, and you can see that it's blocked the CTL4 receptors. And again, the combination between both of them as a PD-L1 inhibitor and CTL4 make the synergistic effect of the combination of the ipilimumab and nivolumab. And for all the people who is treating melanoma, we know that we do have the study of 10 years, approximately 20 to 22% of the patients, about 1,800 patients were in the study, and we have about 20% still alive. And this is considered a record for melanoma patient. And when we look here, we'll find that in this category of the patient, you can find that there is a plateau, and this is after 3 years. Again, regarding the nivolumab and the ipilimumab, this slide is truly important. When we look at the left side of the slide, you can find that when you are doing the combinations between nivo and the ipi, you will find that it's decreasing the proliferation of the cells and have blocking the PD-1 and the CTL4, and so they have a synergistic effect regarding the tumor cells and destruction. And when we look at the other side of the slide, this is one of the main mechanisms regarding the CTL4, which is stimulation of the memory cell. And this is truly important as a mechanism regarding IO combination, that it means the depth of response and also the duration of the response is, this is why we can see in both studies regarding the combination, either Checkmate 227 or the other study, which is 9LA, you can see, and we'll come to this in a minute, that those patients, they have a durable response and the duration of the response comparable to the placebo or the treating arm. We found that those patients, they have a good response comparable. The stimulation of the memory cells, again, this is the key point regarding the ipilimumab, and this is why we found that the patient, they have a plateau, they are keeping and continuing the treatment. And the other issue, even for the patient who are receiving the treatment, if you are stopping, they still can have a response regarding the stimulation of the memory T cells. And this is what the recommendation or the consensus for the investigator of the 9LA. And we'll come to this in a second. When we look at the combination initial regarding the nivo and the ipi as CTL4 and PD-1, we have the history with melanoma, and you can see that the Checkmate 067, this study, it was for the nivo 240 milligram every 2 weeks, and for the ipi it was every 6 weeks, and it was over 90 minutes, and for the RCC as well. And this was the longest survivor regarding melanoma and the RCC. And here for the non-small cell lung cancer, it was 2 years regarding the combination between the chemotherapy and nivo-ipi. And here the dose of the nivo is different. It's 360 IV because it's every 3 weeks, and the chemotherapy of the choice. This is the study which is presented in last ASCO, and this is update. As I pointed out, Martin Ricker from Germany, he is the principal investigator, and this study, it was global between North America, Europe, and Asian as well. And it was first study to date regarding the combination between dual IO and chemotherapy. And it was even just only 2 cycles of chemotherapy versus chemotherapy alone. And the chemotherapy, it was based on the histology. And the update, it was in the last ASCO regarding, but it was first presented in ASCO 2020, and it was one of the late-breaking abstracts. And when we look at the study, you will find that the main part regarding this patient, it was recurrent non-small cell lung cancer, stage 4 disease, no prior systemic therapy, no sensitizer, no driver mutation, EGFR or ALK. It was excluded from the study. EGOC performance 0 to 1. The stratification, it was based on the PD-L1, 6, and histology. Squamous versus non-squamous. And the study included almost 700 patients. They are randomized 1-to-1 randomization, almost in every arm is 360. And you can see that the Nivo here, it's a different dose, which is 360 every 3 weeks. And we know that we do have 3 doses regarding the Nivo. We have 240 every 2 weeks. We have 480 monthly. And every 3 weeks, we have 360. And the AP here, it was in the low dose, which was 1 milligram. And the investigator pointed out that because of the 4 milligram, which is done in, was used in melanoma, most of the patients, they were not tolerated. And this as a combination, this considered a tolerable one. And again, plus the chemotherapy, and the chemotherapy, it was based on the histology. It was gemcitabine versus Taxol carboplatin, and it was or pemetrexate carboplatin, depending on the histology, as we pointed out. The primary endpoint, it was overall survival, and the secondary endpoint, it was PFS, response rate, and and the efficacy by the tumor PD-L1 expression as well. And the quality of life, actually, it was also presented, but it was presented in ESMO. And we have to know that there was a maintenance after the 2 cycles of chemotherapy as a combination, and the maintenance was Nivo every 3 weeks and the EP every 6 weeks. And this is mainly the data regarding, and here, this is the scheme, how we are giving the patient 360 in the first week, and here 1 milligram per kg regarding EP, and 3 weeks for the Nivo, 6 weeks for EP, and then you will need to continue this treatment until this progression, or maximum 2 years, which one it's coming, but most of the patients, they were until this progression. When we look at the update regarding overall survival, you can see that for 2 years, it was 26 versus 38. And for the 1 year, it was 47 versus 63. And this is very impressive. When we look at the start of the graph, when if you are recall the 227 study, which is the combination of Nivo EP versus Nivo combination, we found that it was a crossing at the start. And because of the induction of chemotherapy plus the dual IO, you can see that those patients, they start to separate at 3 months. And this means that this, the chemotherapy can be immunogenic effect and can potentiate the action of the combination. And here in the subgroup, you can found that most of the patients, they were responding. And here we can see that the patient above 75 and the patient was non-smoker, they will not have the same response comparable to the other group. However, when we look at the main part, which is the PD-L1, relevant of the PD-L1 status, you can see that all patients will benefit of the treatment. And this is crucial point because we didn't see that in the combination with chemotherapy or IO as a single agent, specifically here for PD-L1 less than 1%, when you are comparing between the PD-L1 less than 1% or more than 50%, you can find that those patients, they are responding the same manner. And here in the PFS, you can see that those patients, they are keeping the response at the start, and it was mirror image towards having in the PFS in the first year, it was 19 versus 33, and here 8% versus 20%, which means that the patient who's responding initially, they are keeping the response. When you look at the tail of the curve, you will find that the patient who's responding initially, they are keeping the response. And with a significant hazard ratio 0.67, the duration of response was very impressive, and you can see clear separation of the curve. You can see clear separation of the curve after 3 months. And you can see that after 1 year, it's almost double. And after 2 years, it was 12% versus 34. Again, when we look at the PD-L1, which is a crucial point for us, specifically that for the patient with PD-L1 less than 1%, we know that those patients, they are not candidate for IO therapy as a single agent or as a combination, because most of them, they are not responding well to the treatment. When we look at the duration of the response and the response rate, it's 5% versus 58, which is really very impressive. And when we look at the overall survival and PFS, those patients, they have a very good response. And this will give us a hint how to select your patient as a dual blockade and how to give them. When we look at the 50%, you can see that even for the 50%, which is the highest population of the PD-L1, as we know that as a prognostic and predictive factor, you can see that those patients as well, they are responding beautifully regarding the response rate and the overall survival. And you can see that the overall survival for them hazard ratio of 0.67, which is almost the same like PD-L1 less than 1%, and even for the PFS. And this will give us a key, a relevant of the PD-L1 situation, those patients, they can respond. And for the 50%, you can see also the response rate and the duration. And of course, it doesn't came without toxicity. And we have to know that when we look at the grade 3 to 4, it's 48% comparable to 38, which is a chemotherapy alone. But we have to know that the type of toxicity is different than what we have in the chemotherapy. Most of the patients, their main problem is the skin toxicity and diarrhea. And we have to have a conversation with the patient regarding how this combination is different. And also it will come in comparable to 4 cycles of chemotherapy. And the good part, which is presented in this ASCO, that for the patient, only the start of the treatment, you can have the cyst toxicity, and then it is supposed to be decline comparable to the chemotherapy, which is maintaining the toxicity profile. One of the main issues also is and this is a key point regarding that, it was presented again in this study, that the patient who discontinued the treatment because of the toxicity or because of their choice, they are keeping the response. And you can see that the patient who discontinued the treatment, it was 72% comparable to 63, which is the chemotherapy arm, and here 38 versus 54. And this is what I pointed out regarding the stimulation of ipilimumab regarding the memory cells, and those patients, they can keep the response. And when we look at the median overall survival, it's a 27.5, and the 2-year overall survival, it's a 54, and the response rate is 31. Sorry for the delay. Okay. So at 2 years, the overall survival of the first-line Nivo plus EV plus 2 cycles of chemotherapy, it was a durable versus chemotherapy alone. It was 38 versus 26, and the PFS and duration of response. And you can see that it's clearly that those patients, they benefit from the treatments, and there was no safety signal regarding it. And the 56% of the responders who had the adverse events leading to discontinue the treatment, they keeping the response as we found in the data. And here the NC guidelines as a recommendation for the combination of the dual IO. And this is my last slide regarding the safety part regarding ipilimumab and Nivo. The main point that how to select our patient regarding the dual IO, we do have the PD-L1 as a marker and also the TMB. And in the meantime, we have to point it out that we do have the 3 studies which is came negative, like the Mystic trial and the Neptune trial, and it was all came negative. However, the 9LA was the only study which is proven efficacy of the dual IO, and for the patient specifically with low expression of PD-L1, they can have a good chance for this medication. Again, this is the safety card for the patient, and we need to have a good conversation with the patient regarding the treatment paradigm and toxicity as well. Thank you very much for your attention.
Thank you, Mervat. Excellent as usual. And I would like to thank BMS for their great participation with us. It's like, again, like practical and a clinical question. Have you tried it in the clinical setting? Have you ever used this combination? We are seeing some patients, most of the patients we know in lung cancer stage 4, the performance is not that great. But recently, because of staging and advances in lung cancer management and investigation, we start to see patients who are lucky enough in early stage, if not stage 1 and 2, stage 4, but with very limited metastasis, and still the performance is good. How do you choose, how do you select your patient for dual immunotherapy in the clinic setting?
Yeah, this is a very excellent question, Dr. Nafisa. The main point that we do have now the paradigm regarding the metastatic non-small cell lung cancer to just stratify them first squamous and non-squamous, and for squamous and for non-squamous with no driver mutation, we're putting the PD-L1 as a cornerstone for choosing the therapy. So for the patient with PD-L1 more than 50%, we are giving them IO as a single agent. And even for the patient who is young and have a high tumor burden or symptomatic, you can go for the combination between the IO plus chemotherapy. However, for the patient with the PD-L1 between, so in 1 to 49, you still have the option for the combination as well. But for the patient with PD-L1 negative patients, so PD-L1 less than 1%, and we had a couple of patients like this, this means those patients, they are not responding well to even to the combination. And we do have the Keynote 189, and it was a small population of the patient with PD-L1 less than 1%, and it was not conclusive because it was mainly in the cohort. Even in the subgroup, it was not beneficial from the combination. So we do have now clear data, and it was 700 patients in the study, and we found that PD-L1, it's almost was less than 1%. It was almost 400 patients in the study with PD-L1 negative, and they have a great response regarding the PFS response rate and also the duration of response. And this gives us a clue that we need to give those patients the dual blockade because they have a lesser chance of a single agent plus chemotherapy. And the other issue, unfortunately, is still not validated, which is the TMB. In some centers, they are relying on it, but we have to know that the TMB, more than 20%, it can be prognostic, but still not validated, so we are not using it. And even we are not in the clinical practice, we are not doing it. But for what we are doing in the clinical, it's mainly depending on the PD-L1. If the PD-L1 less than 1%, I will consider dual blockade for the patient plus chemotherapy.
Thank you, Mervat. Any questions? No question. I think by this we can conclude.
Thank you very much.
Thank you, Mervat, very much. Thank you.
Thank you.
Thank you. So welcome to the next satellite symposium, which is sponsored by Lilly. My honor and pleasure to introduce Dr. Macmillan Hochmeyer. He's a well-known oncologist in the field of lung cancer. Prof. Macmillan is a consultant of medical oncology. He's the head of respiratory unit at Austria at Clinic for this Dorf hospital. He is a well-known speaker in local and international conferences. He has more than 200 publications, chapters, and he's a reviewer in journals which is mainly looking after lung cancer diseases in the setting of treatment or therapeutic treatment or prevention. Prof. Hoshmer was the liaison, media liaison officer of this steering committee of ASP, and he has long CV, and he was the head of Assembly of Thoracic Oncology from 2004. He was the program director of WCLC in 2 rounds in Vienna 2016 and in Japan 2017. Sorry, Prof. Hoshmer, if I forgot part of your CV. You have excellent and very long CV. Please, Dr. Hoshmer will talk to us about advances and precision oncology and unmet need in patients who are having RET mutation. Doctor, please, the floor is yours.
Thank you very much for your nice introduction and your perfect German. I know for you it's very hard to pronounce my name, and to pronounce Hochmeier is really hard, and also the name of my clinic, Floridsdorf, is also very hard. Understand, and thank you very much for the invitation. I will
Can
try.
you please wait? We have some technical thing. Let me just fix your voice and let you know.
Please tell me when I am allowed to speak.
Please proceed.
Yeah, thank you very much. I hope now it's fine. Thank you very much for the great introduction. Thank you very much for the invitation. And thank you that you pronounced, even it's hard for you, my name perfectly, but Max is absolutely also enough. I'm coming from a lung cancer center in Austria. We have only 8 million people in our country, so it's not that huge in comparison to your country. And a lot of patients are coming to our center, so about 1/4 of all Austrian patients are coming to our center, and here we see about 700 to 800 lung cancer patients per year, and we are really focusing on lung cancer. The topic of RET-altered patients, I put it a little bit broader to put it into target therapy non-small cell lung cancer, to see what is coming, what is going on here in this field, to see how we treat patients now with target therapy. And it's a really huge theme to discuss it, and I will try my best to keep it in the time, the next 30 minutes. These are my disclosures, like you can see here. And you can see in the 90s, to treat lung cancer was very easy. And very simple, but we had only a few treatment options, and the hope for our patients was very limited. So we had to tell patients that they have lung cancer, and the time, how long the patients are living, was very short. Nowadays, we completely have another way how to treat patients, and we try to understand which patient needs which treatment. I remember the time when we gave, after chemotherapy, just allottinib in all patients as an EGFR blocker in this situation, and the success was very limited. We had here 2 months or more overall survival, because some patients had a better response, but we did not understand well which patients this is in this situation. You can see here that all lung cancer patients are different. We have to measure different targets. And when we measure these targets and the patients receive the right treatment, these patients will live longer. But when we measure it and the patients are not getting the right treatment in the situation, or we don't know it if they have the target and we don't treat it, then the survival is worse. So therefore, I really recommend an NGS in all patients, in all non-small cell lung cancer patients. Initially, we just did it in adenocarcinoma, but we also saw that in some patients with squamous cell carcinoma or non-squamous, not only in the adenocarcinoma, we found in different patients a target that we can treat. Initially, the first target that we know is EGFR. Like you can see here, when you find a target, in Austria, we have about 12% of the patients are showing an EGFR mutation. Then the other group is ALK translocation. Then we have found ROS1. We know also MET skipping mutation. We know that HER2 mutation, KRAS, all different targets are possibilities that we can find. And when we have a druggable target, for example, EGFR, MET skipping, ALK, ROS1, RET, all these are targets that we have a druggable target. So also for RET, we have available in our center selpercatinib in the second-line setting that we can treat these patients with this targeted therapy, and we know this is leading to a better overall survival in this situation. On the other hand, for example, KRAS is a target that was for a long time in lung cancer a non-druggable target. But nowadays we know, and we have since February 2021, so since half a year, we have available sotorasib that we can treat patients with a G12C mutation with this mutation, with this target therapy. So perhaps initially we have some targets that we don't know how to treat them, but it's good to know what they have to treat it in also a later line. And it's good to have this information already initially, also when we only have the drug available in the second line. So from this point, when you find the target and you treat it, these patients will live longer, and this is a very important information. This is how we treat nowadays our patients. So in first line, patients mainly on stage 4, but all these informations will come also in earlier stages. For example, we have a trial running in red fusion where we give after surgery patients also in one arm selpercatinib in this indication in the adjuvant setting to get these agents also in earlier stages. Perhaps you discussed the trial, the IMPOWER 030 trial, where we saw that we can give patients in the adjuvant setting atezolizumab that is really reaching a better disease-free survival. We have a lot of trials running in the neoadjuvant setting with chemo IO or immunotherapy. We have the label from osimertinib in the adjuvant setting for EGFR mutated patients. So all these thoughts that we have now in stage 4 will come to earlier stages. And it's important that we know about the driver mutation initially. We know that patients with EGFR, ALK, or RET, or other, we know that these patients are not that well responding also to immunotherapy or immunotherapy plus chemotherapy. So it helps us to understand better the disease when we know already initially the different targets that we can aim. When we find a driver, the patient should receive an MFN of sequencing in this indication, that we really try to sequence patients. If, for example, with EGFR TKIs, we sequence patients, for example, with afatinib or erlotinib plus ramucirumab, followed by osimertinib in this indication to avoid chemotherapy in this setting as long as possible. On the other hand, when we don't find a PDL driver, the PDL1 staining is important, and patients with 80, 90, 100% are receiving in our center pembrolizumab upfront. In patients 50, 60, 70% PDL1 staining, we try to give the Keynote 189 regimen, where I'm a co-author, where we give carboplatin, pemetrexed, pembrolizumab, and in patients lower than 50, we mainly focus on chemo IO, chemotherapy plus immunotherapy, mainly platin, pemetrexed, pembrolizumab. So you see the change when we go back to this slide. Everybody gets chemotherapy. We are far away. Patients are receiving, on the one hand, targeted therapy, or the patients receiving immunotherapy or immunotherapy plus chemotherapy. So the strategy of the treatment is different. We can treat patients different, and it's not chemotherapy alone. So it's just adding chemotherapy to immunotherapy. This is what I wanted to say also initially. When a patient is EGFR, ALK, also we know it for RET, we know it for other agents, other targets. When the patient is receiving immunotherapy upfront or later, the response in these patients is lower. Here, EGFR and ALK mutated patients, overall remission rate 3.6%. In comparison, patients who are negative have a much, much higher overall remission rate. And these patients should receive immunotherapy. But when you find a target, we know that the remission rate is lower. Also, a recent publication from January 2021 from the WLCLC, we saw that patients who are EGFR mutated receiving Nivo or Nivo-Ipi, the response is very low. Still, there is a very small proportion of patients, they can have an efficacy, but in comparison to the target therapy, it's much, much lower. And also what we know, sorry, there's a typing error. We know that when a patient receives a targeted therapy, like here, initially the patient is receiving a target therapy, then he responds, like you can see here. We have 3 types of progression. And this is something also in a different view. When a patient is just progressing on one lesion, the patient should receive a local treatment. So when a patient, like here, has a response still on the initial lesions, but one lesion is progressing, we just perform there a radiotherapy, or when in a single brain met, we continue with the treatment. For example, patient with a RET fusion receives the RET inhibitor, and then he progresses just in one situation. We try to do radiotherapy in this indication, but we don't switch the whole treatment. Also for EGFR, ALK, also for, and we are also doing this in immunotherapy patients, that we try to keep just in a single progression the treatment. In smoldering disease, when the tumor is growing very slowly, we try to keep the treatment and wait for a more aggressive progression when it's very slowly. And in patients with a general progression, especially for target therapy patients, we try to get a rebiopsy, or also when it's available, a liquid biopsy. In our center, we perform NGS liquid biopsy, but the quality is not as good. And in a lot of cases, especially in targeted therapy patients where we don't see a perfect option, then we do a liquid biopsy by FoundationOne. Exception would be EGFR mutated patients. After afatinib or erlotinib plus ramucirumab, we would perform here just a T790M testing. This is where I want to focus in this talk. I want to start with the EGFR mutated patients. And you see here 4,000 patients in our patients. Here, 12.4% of our patients have an EGFR mutation. And in this subtype, we treat these patients differently. In deletion 19, we clearly give afatinib followed by osimertinib. We know that here the response is very good. With afatinib, we are reaching about 12, 13, 14 months. And then we can continue with osimertinib, and we can, from the GeoTac trial, where I'm the first author of, we know that we can extend here 28 months just alone by giving here TKIs. In 35% of the patients, we see elite 5-8R. Here we are a fan of erlotinib plus ramucirumab in this indication, and then we know we are reaching here fast around 18-19% months PFS, and then giving osimertinib in 1/3 of the patients. In rare mutations, we know the best data are for rafatinib, and relatively rarely T790M comes up. And in insertion 20, here we have 2 different agents that we can give out off-label, mobocertinib or amivantamab in first, second, or third line on different trials or named patient use program where we can use it. Here are the different agents that we can use. Erlotinib, gefitinib as a first generation TKI. when you use a first generation TKI, please, erlotinib should be combined here with an angiogenic drug. Afatinib is mainly used in our center in the second generation TKI settings, and then we have osimertinib. Based on our rebiopsy with liquid biopsy, I'm not a fan of using osimertinib upfront, but I think it's also a good option. I want to share with you here my thoughts in this situation. You can see here patients receiving TKI with gefitinib, erlotinib. We always saw a PFS advantage against chemotherapy, but no difference in OS. And the fourth trial that was showing us in deletion 19 that we also found in comparison to chemotherapy in deletion 19 an overall survival benefit. This is the reason why we use mainly in deletion 19 afatinib and in L858R. Here the medical need is higher. Here we are using mainly erlotinib plus ramucirumab. What we do in the time of the progression, we perform a digital droplet PCR. This is something perhaps it's not well known in your center. Normally, liquid biopsy EGFR is COBAS, but we perform digital droplet PCR where we have a higher sensitive method. And we know that the sensitivity of the digital droplet PCR is 3 times higher in comparison to COBAS. And this is the reason why we try to sequence here the patient, and we can sequence here 3/4 of our patients. On the other hand, we have the FLOWER trial. The FLOWER trial was looking against osimertinib, against gefitinib or erlotinib. Erlotinib is here not combined with an angiogenic drug on the one hand. On the other hand, the sequential treatment was not automatically offered. So osimertinib was not given in the second line automatically. So this trial can only answer the question, which drug is the best first line, but cannot tell us about the sequential treatment in this setting. So we saw a very good PFS. We saw 18.9 months PFS against 10.2 months. So in terms of PFS, osimertinib is better, but only 30% of the patients received osimertinib in the second line. And we know from our center, 75% of our patients are receiving in second line osimertinib. So a clear advantage for the sequential treatment. What we also saw is then in the overall survival, the hazard ratio is 0.80 in the FLOWER trial. So the FLOWER trial with 30% in the comparator arm of osimertinib, when you have here a higher percentage of osimertinib, when we have in our center 75% receiving osimertinib, the overall survival would not be for sure, perhaps not even, at least better, I would say. Here is what did the patients receive in second line, and here I wrote it down in the standard of care arm, 31% in the standard of care arm received osimertinib in the time of progression. And when we look at the circulating tumor DNA in the comparator arm, 75% of the patients would have got osimertinib, and this is the reason why the question is sequential treatment or osimertinib upfront is not answered with this trial. What we also do, we are monitoring patients with liquid biopsy in our center. Here you can see patients who are after starting osimertinib in the second line setting. When you do circulating tumor DNA and they are after starting osimertinib negative, the PFS and the OS is much, much better. So monitoring with liquid biopsy based on T790M mutation or other activating EGFR mutations makes sense to understand the disease better for monitoring how good is the overall survival, how good is the PFS for these patients, and when perhaps the patients need a second line. Coming to the second topic, ALK translocated patients, you can see here 20, here we have 3,000 patients where we measured 6.4% have an ALK translocation. The practical guidelines are not really very practical. On the one hand, you can just do everything what you want, crizotinib, alectinib, brigatinib, ceritinib. are allowed in this indication. What is perhaps the most important issue, important information, when you have a progression on a ALK TKI, and this is symptomatic or asymptomatic, it's not necessary to rebiopsy. You can just switch to another ALK inhibitor, and there's no need, for example, also by brain progression, only when it's isolated local treatment, but it's also possible to just switch the ALK inhibitor and there's no need to do whole brain irradiation, for example. The first trial that compared crizotinib against crizotinib was alectinib. So in the ALEX study, we saw alectinib 4 pills in the morning, 4 pills in the evening, reaching a very nice hazard ratio in terms of PFS hazard ratio 0.43, leading that alectinib got gold standard of care in ALK translocated patients. Also in the overall survival, we saw here a improvement in terms of the hazard ratio of 0.67, but the crossover was not allowed. Then I'm a co-author of the ALTA-1L trial, where we compared brigatinib against crizotinib in the same indication. And you see that brigatinib is here given only once daily, initially 90 milligrams, then 180 milligrams. But it makes it a little bit easier to get to have the to be compliant. And we saw the same result in terms of PFS hazard ratio 0.43 hazard ratio. Here, this nearly a quite comparable result for brigatinib and alectinib. This is the reason why both agents are important. What we saw, and I think this is something we find in a lot of trials, that TP53 mutation status is important. Therefore, I recommend to get this TP53 status already in the initial report in, because we know that patients also for EGFR, also for ALK translocated patients, that the outcome overall remission rate PFS is always lower when you see a TP53 status. So when you know it already initially, you know how to handle the situation. Perhaps we need here another strategy on the EGFR also for the ALK translocated patients. And what we know, and this is a publication 1 year ago where we published our lorlatinib data, where we saw that patients receiving after brigatinib, after alectinib, or also crizotinib, brigatinib, then lorlatinib in later lines, that we have a nice duration of response in this indication. What about other targets? Here's the example of BRAF V600. Here we have just a publication from already 2 or 3 years ago. Here 800 patients were measured and 2.3 had the druggable mutation of BRAF. 2.3% have this V600 mutation. This is in line with data from France, data from US, where we see that 2% of the BRAF have a BRAF mutation. And we know that BRAF mutation, like in other diseases, the target, the option of a target therapy is a bad prognostic factor. So BRAF mutated patients, in comparison to others, to the wild type, have a worse outcome. And therefore, also, it's so important that we see it and then we treat it. And here the response rates from patients receiving Tafinlar, Mekinist, dabrafenib, trametinib in this indication, where you see treatment naive patient here, 36 patients with a nice response rate, very nice disease control rate from 75%, and also some complete remissions. And you see here the PFS is 10.8 months and OS is 17.3 months. And when you look at this curve in terms of overall survival and compare it to patients when we did not see this targeted therapy available, that you can see here, it's important that we measure and treat this target in this situation. And what also will come up, that we sometimes find co-occurring genetic alterations. So that means that sometimes, for example, this patient had a BRAF mutation plus KRAS. In the moment KRAS G13C is not a druggable target. So this is relatively easy to solve. But on the other hand, because we cannot treat it, but when it would be a G12C, it would be perhaps possible to treat upfront with tarfin mechanism and then giving the patient sotorasib, or perhaps it's better to combine these two agents. Also here with a BRAF V600 and MET skipping mutation, when you have both drugs available, it could make sense to combine it. But actually, we don't have any data for that. I see my time is getting an end. I have another 2 or 3 minutes. Let me summarize. So it's important that you really try to find initially or perform an NGS, initially finding if there is a driver mutation, EGFR, ALK, ROS1, BRAF, NTRK, RET, MET, skipping mutation, HER2 mutation are all druggable targets that we can target on the one hand here in upfront in labeled, perhaps in a targeted therapy with an MPU, a study that we can try to get these agents upfront, and then in later lines after a long period of targeted therapy that we later give them chemotherapy when it's necessary, also combining with immunotherapy or angiogenic drugs. On the other hand, when there's no driver mutation, immunotherapy plus chemotherapy is recommended. Dankeschön means thank you very much from Vienna. So Dankeschön, you don't have to pronounce it correctly. And I'm hoping for some questions now. Thank you very much.
Thank you, Prof. Max. Thank you very much. Very comprehensive view. And now the floor is open for the questions. I think we don't have question from the audience, but do we have question here from the attendees attending?
I'm happy that you have an audience again in Austria. We don't
have virtual and physical attendee.
This is perfect. This is really great.
So Mervat, do you have a question?
Thank you, Max. That was excellent presentation as usual. My question regarding the ADAURA trial and osimertinib as an adjuvant base. So we do have now the first generation, and also we have the second generation and third generation for the metastatic. So how is the paradigm, will it change?
So in the adjuvant setting, we don't have really good data about the first generation TKIs. So we have here data about gefitinib and erlotinib. These data are really not really convincing. And sometimes the problem is here, they compared against chemotherapy. With the ADAURA trial, we had the possibility to compare, have chemotherapy and adding then osimertinib. So this makes it more clear, the view a little bit clearer. So, and the only data are here for osimertinib. So osimertinib is here fixed. In the stage 4 trial, in the stage 4 setting, it's different. I think the goal in stage 4 is to avoid as long as possible chemotherapy. And this is the reason why I'm a fan of sequencing. And in 75% of our patients, when we do T790M testing with liquid biopsy, based on the digital droplet PCR, we can avoid in 75% of the patients, we can extend the sequential treatment for about 28, 30 months, and this is meaningful. On the other hand, when you go for the best treatment first is also right. This is a strategy you can follow also, and therefore osimertinib upfront is also right. It's just my clinical view, how we perform it in our center.
Perfect. I do have a question also regarding, you pointed out the sequence for the treatment regarding the first line. And we do have, of course, the data for the FLAURA as a third generation, and we do have the NC guidelines. My concern is the CNS metastasis and the probability of incidence of CNS. It was in favor for the patient with third generation. And also we still have the data for the APPLE study regarding the sequence of the treatment. So you don't think that the probability of CNS involvement, it's considered a critical issue to start the osimertinib for the patient, because the first and second, we know that the second generation have a small concentration on the CNS comparable to the first, but again, CNS is a crucial point. Thank you.
Thank you very much for the very important question. Here, both ways are also right. Here I wrote a review about this topic in Targeted Oncology 2 years ago. We know afatinib from the LOXLAN 3, 6, and 7 trial is avoiding brain mets. Also here, patients with brain mets were included. So we know on the one hand, afatinib is very good working in the brain, and we published this data also in Future Oncology. On the other hand, we know erlotinib plus ramucirumab, for example, when you use this agent, the probability of brain mets is much, much lower in comparison to those patients where you start just with erlotinib alone. So we can also find here an argument that you use these agents in upfront and then using osimertinib as an cerebral active agent later, meaning that when osimertinib progress, when you have osimertinib first line and then you have a progress in the brain, you have to use whole brain irradiation. And then you have no active drug in the brain. So this is for me more and more an argument to use the sequential treatment in brain mets. But on the other hand, when you don't have the digital droplet PCR available and you cannot do this kind of sequential treatment that easy, I understand that you go for osimertinib. And the guidelines say both ways are possible. It depends what is your experience. We're using osimertinib since 2015, and the label for osimertinib first line is since 2017 or 18. So I would say 3/4 of our colleagues in Austria are still sequencing based on our experience with liquid biopsy, because we can really sequence 75%. When you go to the border, so Switzerland, for example, everybody's using osimertinib because they don't have the experience. And I can understand both ways in this indication.
Thank you.
Thank you. I do have question. Thank you, Prof. Max. I saw your center is very busy. You are seeing around 800 patients per year. Do you do liquid biopsy upfront, even in a patient who are having excellent performance or very good performance status? Do you do liquid biopsy or you do both? And in your center, do you have like a comparison between the output from liquid biopsy and the output from tissue biopsy?
About which patient group are we talking? So when we have
EGFR patient.
EGFR, okay.
EGFR.
So when I have an EGFR mutated patient, for me it's interesting, is there TP53 status, yes or no? When we know TP53, we have to follow up this patient more carefully because the outcome of these patients is worse. This is just a general predictive marker or prognostic marker that we know. On the other hand, we test immediately with liquid biopsy initially to see if on the treatment, the patient is going down with liquid biopsy. So after 3 months, we control the liquid biopsy. And when we see it disappeared out of the blood, we know this is prognostic, a very, very good marker. We don't have to follow up this patient so carefully. But when it's still there, it's perhaps necessary to add an angiogenic drug. Perhaps it's necessary to add here chemotherapy, and we discuss it. Even it's not clearly in studies, but we saw that the outcome of these patients is worse. So we really try to monitor patients. When we see the T790M mutation is coming up and the patient is feeling worse in the monitoring, we start very early with osimertinib, based not clinical progression, liquid biopsy progression, and radiological progressions. All these are markers that we can use here, and therefore we monitor patients in this indication, especially after 3 months, and then in about 3 or 6 months follow up with liquid biopsy. The T790M mutation that we are testing and the subtype of EGFR costs about only €100. So it's not an expensive way to test. The rest of liquid biopsy testing does not make so much sense to do it immediately. NGS testing would come when there's a progression and we don't understand the mechanism.
Oh, thank you. Thank you very much. I think by this we can conclude our session. Thank you, Prof. Max, for this excellent review, and hopefully we'll see you soon physically in Riyadh. Thank you. Hello, thank you, Prof. Max. Thank you very much.
So I can leave. Thank you. Bye.
Thank you for the excellent presentation and excellent output.
Only wanted
Thank
to
you.
be sure that I'm allowed to leave. Ciao.
Thank you. Our pleasure to have you here. Thank you.
Ciao.
Yeah, I think we can proceed to last session of the day. This session, I'll be chairing it with my colleague, Dr. Munira. Dr. Munira is a consultant of adult medical oncology at Prince Sultan Malaysia Hospital. Dr. Munira has a special interest in breast and lung cancer. The session title is the role of precision medicine in the lung cancer. Dr. Munira will be sharing this session with me virtually. Dr. Munira, please. So, Munira, are you on? So maybe she will introduce the next speaker. It's my pleasure.
I am on. Sorry.
Yeah, please, Munira, go ahead.
Yeah, sorry for that. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody, and thank you, Nafisa, for your nice introduction. And I would like to thank the organizing committee for arranging this scientific event. As we reach the end of the first day of this scientific event, and we know that the human concentration declined at the end of the day, but I'm telling you that we have three excellent speakers who will talk about a common scenario of lung cancer and the treatment. We will start with Dr. Mervat Mahrous, a medical oncology consultant, oncology department at Prince Sultan Military Hospital, and assistant professor of oncology, Faculty of Medicine, Asyut University, Egypt. And she will talk about the management of stage 4 non-small cell cancer with EGFR mutation. Welcome, Dr. Mervat, and you might start.
Thank you very much, Dr. Munira, for introducing me, and it's my pleasure again. And I would like again to extend my thanks to Dr. Nafisa and Dr. Ashwaq and Professor Qattan. They assigned me a very nice topic, which is the management of stage 4 non-small cell with EGFR mutation. And I think we had a very beautiful presentation by Dr. Maximilian. And the point that the EGFR, it's a very good example about the precision medicine. And since the introduction of the EGFR mutation since 2005, I think it was changing the history of lung cancer. So it's not moving, guys. Again, lung cancer is not one disease, and we got our lesson that we are dealing with lung cancer on the subcategory as the histological, and even moving from the histological part from the non-squamous to the category of the driver mutation. When you look at this pie, you can find that every category of this and every category has a drug on this pie, what we call the actionable mutation. And even in this, because this slide since 2019, we have updated one with the red and with the NTARC. And you can see that the KRAS even have a 30% of as detection, and about 13% it can be KRAS G12, and for the EGFR about 15%, and in the Western population, and even it's higher in Asian, and regarding Saudi Arabia, it's even higher, between 15 to 20%. The ALK is fixed between, it's almost the same, 5%, and for the HER2, it's a 3%, and ROS1 from 1 to 2%. When we look at this pie, we found that this is the most specified as a treatment, and when look at the left side of this, the right side of the slide, which is the squamous, you find even there is plenty of mutations, but unfortunately we don't have drug specified for the squamous, and we're still treating with chemotherapy, and thanks for the immunotherapy as well. And when you will find that P10 and the PIK3A, it's different than the breast cancer population. So we are looking forward to have the same category like the non-squamous, and to be treated specifically based on the mutation. Again, this is always depending on the survival of the lung cancer and on the presentation. So the highest one, which is the 56.3, this is mainly for the patient who is presented with a localized disease. However, 4.7, this is for stage 4 disease, which is the majority. About 50% of the population, they are presenting with metastatic disease. When we look at this data, this slide, it's based on the Saudi population study, and it was published by Professor Jazia. And you see that the population of EGFR is higher comparable to the Western population, which, as I pointed out, 15%. This slide, it was presented in 2006, and you can see on the upper part of the slide that this patient has a bulky lesion on the right side, and it takes the middle and lower lobe, and you can see that this patient, after 2 months of treatment, and in the first one it was in March, and the second one it was in May, and this was the after giving the patient gefitinib, and this was presented by Tony Mahrous, who was the principal investigator of the IPAS trial. And when we look at this slide, Mahrous from MD Anderson, he presented that retrospective analysis that the patient with a target therapy comparable to the patient without target therapy, you can see a clear benefit for the patient with a driver mutation who's treated with target therapy comparable to chemotherapy. And since this, you can see that the patient who is treated with chemotherapy, we consider them undertreated patients, because the best outcome for the patient to be treated them based on their mutation, and you can see that the overall survival response rate. What the beautiful regarding the EGFR, that even we passed the period from the EGFR as a mutation, we have now talking about the EGFR as a common mutation and the uncommon mutation. When you look at this slide, we found that about 46% of the patient, they can be exon 19, and we consider it as a sensitive population, and followed by the exon 21, which is the L85 population. And when we look at the uncommon mutation, which means exon 18 and exon 20, and we'll come to this in a second. The main point that we are transforming now to stratify the TKIs to common mutation and the uncommon mutation, because the first generation and second generation and even third generation, they are not responding well to the uncommon mutation, and we have some options for them. And this is what I was talking about. This is uncommon mutation. You can see that because we are treating the patient now based on the type of mutation, and so we are detecting every patient. This was presented last year, and you can see that the uncommon mutation between 10 to 15%. And some of the patients, they may not respond to the TKI because mostly they are not the same treated, and the response for the TKI for them it's comparable to the exon 19, and the exon 21 is different. And even they found that the non-Asian population, they have a higher comparable to the, the non-Asian population has lower comparable to the Asian. You can see that 61 comparable to 35%. And again, this is the same scenario. You can see that 56 comparable to 21 and 13% in the Europe. IPAS, it's considered history. And you can see that this trial, it was published in New England Journal of Medicine by Tony Monk from Hong Kong. And he is very well known in the EGFR field and has many publications. The IPAS study, it was the first study to date, gefitinib 250 milligram per day, comparable to the chemotherapy. And it was a hit at the time because we are hitting the taboo that we are lung cancer patients, how we are giving them oral medication, and this will affect. And when you look at the primary endpoint, it's PFS, and the secondary endpoint, it was the response rate, overall survival, and there was exploratory regarding the EGFR mutation and the protein as well. When you look at this graph, you will find that it's a clear benefit when you look at the right side of the slide, which is the EGFR negative. Those patient has a fertility, and the chemotherapy was superior to the EGFR. And for the EGFR patient, you can find the hazard ratio of 0.48. This means that you need to detect the EGFR for this patient as a type of mutation, and based on this, you can give them the TKIs. Otherwise, this patient can be candidate for chemotherapy, and they will not benefit at all from the EGFR inhibitory TKIs. And the one came down the road, which is the orlatinib or study, and you can see that they got the lesson, and they stratified the patient from the start, and it was mainly for the patient with EGFR mutation, and you can see that a clear benefit for this patient, and again, it was comparable to the chemotherapy with hazard ratio 0.37. This is the PFS for, there is no difference between the orlatinib and gefitinib, and you can see that it's very similar with some superiority regarding orlatinib, but it's considered both the same, and both was first generation TKI. But however, that orlatinib was more wide because it's mainly was wider in some centers comparable, but again, it's very similar to each other. However, most of the patients, they can develop resistance, or they generate another second generation, which is afatinib, which is an irreversible one, and they look at if it is comparable to the first generation, and you can see that it's almost the same for LUX-Lung 3 and 6, and even for the LUX-7, which was comparable to the gefitinib, it was almost the same. There was the PFS was superior, however, the overall survival was no benefit, with some signal of superiority of the afatinib. However, the toxicity profile was high. And this is a graph for the LUX-3 and 6, and you can see that to this patient comparable, the control arm, it was the chemotherapy. And the only study which is controlled looking for the stratification regarding the deletion of 19 and 858. And you can see that for the deletion 19, it was a significant benefit. However, in 858, it was not ranking to be significant. It was 10.8 to 8.1. And this was again comparable to chemotherapy, which is cisplatin pemetrexate. LUX-7, as I pointed out, it was the first study to compare second generation with the first generation, and the primary endpoint, it was PFS, and the secondary, it was the OS and the response rate. And you can see there is some superiority, but and the p-value, it was 0.201, and the overall survival, you can see that there is no significance, it's 0.2. Another second generation, which is the dacotinib, and we have to point it out that either the afatinib or the dacotinib, both of them, the toxicity profile was high and the intolerability was recorded for most of the patients, and about 25% of the dacotinib arm, they were need modification, and the patient was out of the study. And in this study, they were not included CNS metastases as well. However, when we look at the PFS, you can find that the 14.7 versus 9.2. This means that this is a good drug. However, sometimes you can have the clinical benefit is more important than just only that you can have a figure. So that the toxicity profile, this is even make the most of the centers, they didn't adapt it. So you can see here even the Archer 105, and the overall survival was not significant, and there was a crossing on the line. In the meantime, there has FDA approval for the dacotinib as well, but so far we don't know exactly who is using this medication at that time, because it was concurrent with the time of the FLORA study as a third generation. When we look here, we found that it's almost similar between similarity with some superiority regarding the lung-3. You can see that the PFS 13.6 versus 9.5 and 8.4 for the other medication. And here, like a comparison between all of them, and you can see that the dacotinib is the highest on the road. It's 14.7 comparable to 13.6 for the afatinib, and orlatinib 13.1. And again, you can, it will depend on the availability, but we have to know that about 60% of the EGFR positive patients, they may have CNS involvement, either that at the time of presentation or the patient, they can develop it. And so the CNS crossing and the concentration on the CSF, it's really a crucial point. Down the road, you will find that those patients, they will develop resistance. Even for the third generation, you will find that there's a resistance as well. So there will be acquired, there will be a primary resistance or secondary resistance. This is why from the first generation, they developed the second generation, and then they developed the third generation. And the third generation, first of all, it was used for the patient who developed T790 as pointed out by Max, and the FLORA study, the phase 3 study, and the study was addressing the point for the third generation randomization comparable to EGFR TKIs. They included first generation only, they did not include the second generation on the study, and it was 1-to-1 randomization, almost 300 patients in every arm. And the primary endpoint, it was PFS, and the secondary, it was response rate and the overall survival. And definitely the study made the primary endpoint, and I have to point out that the patients were included, it was exon 19 and 858, and no prior systemic therapy and stable CNS metastasis, and they include the imaging that was mandated before including in the study. And the FLORA, as you can see, that the PFS was 18.9 with hazard ratio 0.46, and the overall survival, it was 38.6 and hazard ratio of 0.8, which is highly significant comparable to the first generation. And one of the main issues that either with CNS metastasis or without CNS metastasis, the hazard ratio is almost unchanged with 0.47 comparable to 0.46 for the patient with CNS metastasis. And you can see clear separation of the curve for this patient. And this is the full analysis that even was presented in ESMO. And you can see that those patients, they are keeping, and the hazard ratio of 0.48 with the median follow-up 12.4 comparable to 7, which is almost double. When you put all together and we can compare, you can see that the LOX7, which is the afatinib, gefatinib, Archer, which is the dacotinib, gefatinib, and the FLORA, which is osimertinib standard of care, which is the first generation. And you can see that the highest down the road is osimertinib as a third generation, and you can expect that because it's mainly the main concentration and the response rate and the PFS as well. And this slide, even we are putting the orlatinib plus bevacizumab, and relatlimab plus ramucirumab, and even gefitinib, which is the highest one, gefitinib plus chemotherapy, you can see that the highest down the road is the 52 months regarding overall survival. But however, it's not uneasy to give the patient with chemotherapy plus gefitinib, and it was not adapted in most of the centers to give, and we don't know even who's the patient we select for this category. Of course, we do have the new flora for now, and we do have some data for the combination between osimertinib and Avastin, is still waiting for the results, and who is the patient can be candidate for the study. This is the NC guidelines putting the osimertinib as a third generation as preferred. However, not all the centers can have the osimertinib, so the other options can be erlotinib, afatinib, gefitinib, and this is always depending on your choice and the availability and what you have in your center. Again, even for the third generation, you can have resistance, but the resistance is different because it's covering T790, but you will have the MET amplification, and or you can have the small cell type. And this is why important to have a liquid biopsy or a biopsy for this patient. This is truly important. As I pointed out regarding the FLORA-2, it's osimertinib plus cisplatin, cisplatin pemetrexate, and we are waiting for the results of this study in 2026, inshallah, and we can see that if there is a superiority and what category of patient we can give. Another study which is pointing out the sequence, so it's an Apple study, osimertinib versus gefitinib, and you can do ctDNA for this patient to detect T790 followed by osimertinib, and the third arm, which is the gefitinib, with this progression by radiological, and we are very anxious to see this study, but this study will be presented in 2023. Inshallah. Other study, which is osimertinib plus bevacizumab, the phase 2 study was very promising, and now they are conducting the phase 3 study, and we will see that it may be the anti-angiogenic plus osimertinib, they can have a superior, and maybe you can select the patient, and we'll look at resistance as well. And again, this is how to treat EGFR mutation patients as a first line, second line, and third generation. Thank you very much for your attention.
Thank you, Mervat. Very excellent presentation. I think we can proceed to the next talk. So our next speaker is our colleague and friend, Dr. Hamid Alhusaini. Dr. Hamid is a consultant of adult medical oncology at King Faisal Specialist Hospital and Research Center. Dr. Hamid will talk to us about minimizing and sequencing treatment of ALK-positive patients who are having stage 4. Dr. Hamid, please.
So thank you for inviting me to be a speaker in this amazing conference. So my talk, as mentioned by Dr. Nafisa, will be mainly about ALK-positive non-small cell lung cancer. So we know that 5 to 7% of patients with non-small cell lung cancer have echonoderm microtubule associated like protein 4 anaplastic lymphoma kinase gene fusion. It is mainly seen in younger age with a median age of 52, nephro or light smoking, and adenocarcinoma. Usually it is mutually exclusive with the EGFR or KRAS mutation. FISH, immunohistochemistry, next generation sequencing are approved companion diagnostic tests. And you can see by FISH, usually if patient has ALK-positive, probe are separated, and there is a splitting of the red and green signaling. It is usually highly sensitive to the ALK targeted therapy. So the first, I will talk about the role of the first generation ALK inhibitor, which is crizotinib. So the first trial is a Profile 1007, which is a phase 3 randomized trial comparing crizotinib as a second line versus single agent chemotherapy, either pemetrexate or docetaxel. And you can see there was a higher overall response rate with the crizotinib, 65% versus 20% with the chemotherapy. Median progression-free survival was around 8 months versus 3 months with the chemotherapy. Then the second trial is a profile 1014, in which crizotinib was randomized as a first line to pyruvate platinum-based chemotherapy. And the same overall response rate with the crizotinib was 74% versus 45% with the chemotherapy. The median progression-free survival was around 11 months versus 7 months with the chemotherapy, with the hazard ratio 0.45, which was a significant. So what about comparing the first generation ALK inhibitor with the second generation? So the first study is the Japanese Alexis study, in which 207 patients with ALK positive non-small cell lung cancer, ALK naive, randomized either to the alectinib or crizotinib. And the primary endpoint was progression-free survival. And you can see there was a significant improvement in the progression-free survival with the alectinib as compared to the crizotinib. With a median follow-up of 42 months, it was around 34 months with the alectinib versus 10 months with the crizotinib. This led to the global study, Alexis study, in which 303 patients from different countries with advanced ALK positive non-small cell lung cancer, ALK positive confirmed by immunohistochemistry, treatment naive, randomized either to the alectinib or crizotinib. And the primary endpoint was progression-free survival. So in this study, with a median follow-up of 28 months, there was a significant improvement in the progression-free survival with the alectinib as compared to the crizotinib. It was 11 months versus 35 months with the hazard ratio 0.43. Also, time to CNS progression was prolonged with the alectinib as compared to the crizotinib. So the cumulative, among the patients with the CNS metastasis at baseline, the cumulative incidence was lower with the alectinib, 16% versus 58% with the crizotinib. Also, among the patients without CNS metastasis at the baseline, the cumulative incidence was around 4.6% with the alectinib as compared to 31.5% with the crizotinib. Overall survival result is still not yet mature, with only like 37% of the data collected. But you can see there was a trend toward the improvement in the survival with the alectinib as compared to the crizotinib. It was 57 months with the crizotinib versus not reached with alectinib. When you look for the adverse event, grade 3 or higher adverse event were lower with the alectinib. It was 41% versus 50% with the crizotinib. And we can see GI upset, peripheral edema, raised liver enzyme, and visual impairment were more common with the crizotinib as compared to the alectinib, while increased blood bilirubin, myalgia, anemia, and weight increase were more common with the alectinib as compared to the crizotinib. The third study about alectinib is Alicia trial. In this trial, 187 Asian patients with advanced ALK positive non-small cell lung cancer treatment naive. ALK was confirmed centrally. Patient randomized 2-to-1 to receive either alectinib or crizotinib, and there was no crossover. And the primary endpoint was investigator-assessed progression-free survival. And the same, the median progression-free survival was significantly prolonged with the alectinib as compared to the crizotinib. It was 11 months with the crizotinib as not reached with the alectinib. Intracranial disease response was 94% with the alectinib as compared to 29% with the crizotinib. Overall survival result is still not yet mature. The same, cumulative incidence of the CNS progression was lower with the alectinib as compared to the crizotinib, 7% versus 35.5%, and this leads to the approval of the alectinib as a first line for ALK positive non-small cell lung cancer. What about the second next generation ALK inhibitor, which is brigatinib? So in this phase 3 trial, patients with the advanced ALK positive non-small cell lung cancer, ALK naive, randomized either to the brigatinib versus crizotinib. And the same, median progression-free survival was significantly prolonged with the brigatinib. It was 24 months versus 11 months with the crizotinib, and the hazard ratio was 0.49, which was a significant. The same, intracranial progression-free survival was prolonged with the brigatinib as compared to the crizotinib. So the median was not reached with the brigatinib versus around 6 months with the crizotinib, with the hazard ratio 0.27, which was a significant. When you look for the adverse event, grade 3 or higher adverse event was around 61% with the brigatinib as compared to 55% with the crizotinib. And the most common adverse event with the crizotinib was GI, like diarrhea, nausea, raised liver enzyme, vomiting, constipation, peripheral edema, and visual impairment were more common with the crizotinib, while increased blood CK, cough, and hypertension were more common with the brigatinib. And the special side effect, it was interstitial lung disease and pneumonitis, was around 4%, which is higher with the brigatinib as compared to 2% with the crizotinib, and 3% observed within 14 days of starting treatment. The adverse event leading to the discontinuation was higher with the brigatinib, 12% versus 9% with the crizotinib. The third medication is ceritinib. So in this trial, ASCENT-4 trial, 376 patients with ALK-positive non-small cell lung cancer as a first-line patient randomized either to the ceritinib, which is 20% more potent than alectinib, versus platinum-based chemotherapy. And the same, the median progression-free survival was prolonged with the ceritinib as compared to the chemotherapy, 17 months versus 8 months, with a hazard ratio 0.55. Overall response rate was higher with the ceritinib, 72.5% versus 26.7% with the chemotherapy. Median duration of the response was prolonged with the ceritinib, 24 months versus 11 months with the chemotherapy. So this led to the FDA approval of both ceritinib and brigatinib to be given as a first line. Then I will talk about CROWN study. So in this study, 296 patients with advanced ALK-positive non-small cell lung cancer, treatment naive, asymptomatic treated or untreated CNS metastasis were allowed. Patient randomized either to the lorlatinib, which is a third-generation ALK inhibitor, or crizotinib, and the primary endpoint was progression-free survival. And in this study, the same. I mean, the median progression-free survival was significantly prolonged with the lorlatinib as compared to the crizotinib. So it was not reached with the lorlatinib versus 9.3 months with the crizotinib. The hazard ratio was 0.28. And you can see at 1 year, the progression-free survival rate was around 78% with the lorlatinib as compared to only 39% with the crizotinib. Intracranial time to progression was prolonged with the lorlatinib. It was not reached versus 17 months with the crizotinib, with the hazard ratio 0.07 with a significant p-value. When you look for the adverse event, grade 3 or higher adverse event were more with the lorlatinib. It was around 72% versus 56% with the crizotinib. But the adverse event that lead to the discontinuation was 7% with the lorlatinib as compared to 9% with the crizotinib. When you look for the adverse event, you can see the most common adverse event with the lorlatinib is mainly hypercholesterolemia, hypertriglyceridemia, peripheral edema, weight increased, peripheral neuropathy, and cognitive effect. So this leads to also the FDA approval of lorlatinib as a first line. Option under investigation in the first line setting, still not yet, getting the FDA approval. This is EXALT-T3 trial. In this trial, 290 patients with advanced non-small cell lung cancer, ALK-positive confirmed by central test by FISH, treatment naive, patient randomized either to the ensertinib, which 225 milligram daily, or crizotinib. So in this study, the same, median progression-free survival was significantly prolonged with the ensertinib, which is a second-generation ALK inhibitor, around 26 months versus 13 months, with a hazard ratio 0.51 with a significant p-value. When you look for the adverse event, you can see the most common adverse event associated with the ensertinib is the rash, which is around 70%, and also raised liver enzyme. But the adverse event that leading to the drug discontinuation was around 9% versus 7% with the crizotinib. Now we'll talk about acquired resistance. We know almost all patients who are treated with the ALK inhibitor will develop acquired resistance. When you look for the patient treated with the crizotinib, you can see the most common cause of acquired resistance is a bypass signaling, like abnormality in epidermal growth factor receptor, KIT, or insulin-like growth factor, and it is around 50 to 70%. Secondary ALK mutation occur in around 1/3. ALK amplification, which can occur either alone or in a combination with the ALK mutation, it is around 18%. When you look for a patient who treated with a second-generation ALK inhibitor, you can see the most common cause of acquired resistance is secondary ALK mutation, which is around 50 to 70%. And the most important, this is G1202R, which is a highly resistant ALK inhibitor to both first-generation and second-generation ALK inhibitor. How to manage acquired resistance? So for a patient who treated with the crizotinib, So this is a phase 3 ALOR study in which 107 patients with advanced ALK-positive non-small cell lung cancer previously treated with a platinum-based chemotherapy and crizotinib, randomized either to the alectinib as a second line versus single agent pemetrexed or docetaxel. And the primary endpoint was progression-free survival. So in this study, the median progression-free survival was significantly prolonged with the alectinib. It was around 10 months versus 1.4 months with the chemotherapy with the hazard ratio 0.15. Overall response rate was higher with the alectinib, 37.5 versus only 3% with the chemotherapy. Median duration of the response was around 9 months with the alectinib versus only 3 months with the chemotherapy. When you look for the CNS overall response rate was higher with the alectinib, 54% versus 0% with the chemotherapy. Grade 3 or higher adverse event were lower with the alectinib, 27% versus 41% with the chemotherapy. The other medication is the ceritinib. So in this ASCEND-5 study, 231 patients with advanced ALK-positive non-small cell lung cancer, prior crizotinib and developed progression of the disease, and patient may receive 1 or 2 prior chemotherapy, including platinum doublet, randomized either to the ceritinib or single-agent chemotherapy, pemetrexed or docetaxel. And here, the median progression-free survival was significantly prolonged with the ceritinib as compared to the chemotherapy, was around 5.4 versus 2 months with the hazard ratio 0.49 with a significant p-value. Overall response rate was higher with the ceritinib, 39% versus 7% with the chemotherapy. Median duration disease control rate was higher with the ceritinib, 76.5% versus 36% with the chemotherapy. The third medication is brigatinib. So in this phase 2 trial, which is ALTA trial, 222 patients with the advanced ALK-positive non-small cell lung cancer who developed progression of the disease on crizotinib, randomized either to the lower dose of brigatinib, which is 90 milligram daily, or higher dose 180 milligram daily. The median progression-free survival was around 9 months with the brigatinib and around 17 months with the higher dose. The median overall survival was around 29.5 months with the brigatinib versus 34 months with the higher dose. Overall response rate 51% with the lower dose versus 56% with the higher dose. And you can see the pulmonary toxicity was around 6%. Grade 3 or higher was around 3%. Lorlatinib using as a treatment for a patient who developed acquired resistant. So this is, as we know, third generation ALK inhibitor. So in this phase 2 trial, 198 patients with ALK-positive non-small cell lung cancer who developed acquired resistant was treated with lorlatinib. And we know lorlatinib has activity against the most acquired resistant developed by either first and second generation ALK inhibitor, including what we know the most acquired resistant, which is G1202R, is still sensitive to the lorlatinib. So in this study, among the patients who treated only with the prior crizotinib plus or minus chemotherapy, overall response rate with the lorlatinib was 73%. Median duration of the response was not reached, and intracranial overall response rate was around 68%. Median progression-free survival was 11 months. For a patient who treated with the second generation ALK inhibitor, either as a 1 line or as a second or third line, the overall response rate was around 40%. Median duration of the response was around 7 months. Intracranial overall response rate was around 46%, and median progression-free survival was around 7 months. So this is like how to manage the acquired resistance. So usually we prefer to treat patients with the second generation ALK inhibitor. We prefer to use alectinib, but if you don't have alectinib, maybe use brigatinib, ceritinib, or if you don't have second generation, you may treat with the crizotinib. If a patient has a single site progression, you may consider local therapy like surgery, radiation, or radiofrequency ablation and resume the same TKI. If a patient has asymptomatic indolent growth, multiple site, you may continue the same ALK inhibitor. But if a patient develops symptomatic multiple site, if a patient treated with alectinib, then you can switch to lorlatinib. If a patient treated with the crizotinib, you may use alectinib first and then later lorlatinib. So this is the last slide. Thank you.
Thank you very much, Dr. Hamid Alhusaini. It is a very informative and useful information. We'll move now to the last session, and it will be about the role of adjuvant immunotherapy and resectable stage of non-small cell lung cancer from stage 1A to stage 3A. And I always ask myself a question: if a patient progress while he's on maintenance immunotherapy, as we know, there is no evidence supporting using another immunotherapy if we fail one. But if there is a minimal disease progression and PD-L1 is highly positive, there is a way to try? I don't know, and maybe we will not find an answer for that. Without further ado, I would like to introduce Dr. Samah Alrehaily, consultant adult medical oncology with a special interest in GI malignancy at King Abdulaziz Medical City, Jeddah. Dr. Samah, the floor is yours and you might start.
Sure, can you hear me?
Yes.
Okay, Assalamu alaikum. Thank you for the organizing committee to invite me to present today. My name is Samah Alrehaily, and today I will be talking about the role of adjuvant immunotherapy in the resectable stage 1B to 3A non-small cell lung cancer. So I will be talking about a little bit of backgrounds, and then also I will talk about the post-operative immunosuppression and the idea behind thinking about immunotherapy in the adjuvant setting. I will talk also about the Empower 010 and then the neoadjuvant versus adjuvant treatment, and then Checkmate 816. So among patients with resected non-small cell lung cancer, the survival at 5 years range from 80 to 40%. And of course, the higher the stage, the lower the survival. And ways to increase survival is number one, by detection at earlier stage, and of course, by implementing a good screening programs. And then the second thing is to improve efficacy of perioperative therapies. We do have meta-analysis in the neoadjuvant setting as well as in the adjuvant setting, and both adding to surgery yields a 5% improvement in 5 years survival. So the current perioperative therapy paradigm is, so if the patient is upfront resectable, so then we go for surgery followed by adjuvant chemotherapy, and then now we know from the ADAURA trial, osimertinib is also an option and FDA approved for EGFR positive patients in the adjuvant setting. If the patient is not upfront resectable, then neoadjuvant concurrent chemoradiation followed by surgery. Non-small cell lung cancer has seen a move to personalized healthcare with immunotherapy and targeted therapy. And as I just mentioned, the osimertinib from the ADAURA, and we have lots of ongoing phase 3 adjuvant TKI trials like the ALINA for alectinib, Alchemist ALK, a US study. So we are now starting to see a practice-changing phase 3 data with these therapies in resected non-small cell lung cancer. In ASCO 2020, oncologists had a long discussion about the ADAURA, and in ASCO 2021, we saw the result from the Empower 010. So for the goal of adjuvant immunotherapy is to prevent relapse by targeting micrometastases. And in this slide, you can see from a preclinical studies, actually they tested a patient with lung cancer, and they took lung cancer tumor cells and also a lung cancer normal cells and a blood, and then they barcode the or pair the cells, and then they followed up, and they found that they tried to study the tumor immune microenvironment, and they found that there is a decrease in the natural killer cells and also the dendritic cells, which is very important to kill micrometastases. And also there was an increase in the regulatory T cells and the expression of PD-1 and CTLA-4. And this slide is again from, as you can see, from the surgical post-surgery, there will be a surgical trauma and other factors like sepsis, blood loss, hypothermia, anastomotic complications, anesthetic and analgesics. And this will release clotting factors, VEGF, PDGF, and TGF-beta. And this will increase the catecholamines and prostaglandin, and this will lead to expansion of immune regulatory cells, which decrease interleukin-2, 12, and interferon alpha, and increase the regulatory T cells, macrophages, and MDSC. And this will decrease the function and the activity of the T cell and natural killer cell and cause an immunosuppression. That what we think is actually lead to the immune system is not fighting the micrometastases and also increase expression of PD-1 and CTLA-4. And from this preclinical studies, the idea of implementing or testing the adjuvant immunotherapy. We have an ongoing phase 3 adjuvant trials. We have Nivo, pembrolizumab, the K091. Hopefully we'll hear soon from this result. And also we have durvalumab and atezolizumab. Atezolizumab, IMpower 010, was presented in the ASCO 2021. It's a phase 3 global study of atezolizumab versus best supportive care. And in this trial, they took a completely resected stage 1B to 3A non-small cell lung cancer, and the tumor was more than or equal to 4 centimeters with excellent performance status, lobectomy or pneumonectomy. And then patient received a platinum doublet chemotherapy, either cis-pem or gem or dosi or ven, between 1 to 4 cycles, and then they were randomized to atezo versus best supportive care. No crossover was allowed. And the primary endpoint was the DFS, and the secondary endpoint is OS. And how they actually did their statistical analysis, it was hierarchical. So they tested the DFS and PD-L1 TC1 or more in stage 2 to 3A. And then if this is positive, they move and test the DFS in all randomized stage 2 to 3A population. And then if this is positive, they test for the DFS in the ITT population. And if this is positive, then they test for the OS in the ITT population. When we look at the baseline characteristics, it was well balanced. The non-squam, it was around 65%, stage 1B around 12%, stage 3A around 41%. When we look at the PD-L1 more than or equal to 1, it was 54.6%. And this is lower than what we saw with the Pacific, which was around 67%. The primary endpoint, so the DFS and the PD-L1 TC more than 1 or equal to 1 in stage 2 to 3A population, and the median follow-up was at 32.8 months. The median DFS was not reached in the atezolizumab arm, and in the best supportive care, it was 35.3, and the stratified hazard ratio is 0.66. When we look at the subgroup analyses, as you can see here, all patients actually hazard ratio was 0.66, and I will go through the subgroup analyses in the coming slides. So in the DFS in all randomized stage 2 to 3A population, the median DFS was 42.3 in the atezolizumab arm and 35.3 in the best supportive care arm, and the stratified hazard ratio is 0.79. When we look at the subgroup analysis, as you can see here, currently smoker and never smoker crossed the line, EGFR positive and ALK positive crossed the line, and then in the PD-L1 status, 50 or more, hazard ratio is 0.43, and TC more than or equal to 1 is 0.66, and the TC negative or PD-L1 negative crossed the line. When they reached their third statistical analysis, the DFS in the ITT population did not cross the significance boundary at this interim DFS analysis, and we're waiting for more data from the IMpower 010. Overall survival data, it was also immature, and hopefully we'll hear soon about this as well. In terms of the safety summary, of course, adding more treatment will come with the cost of toxicity, but there was nothing unusual from what we already know from previous trials from using atezolizumab. And the conclusion from the IMpower 010, it's the first phase 3 study of cancer immunotherapy to demonstrate DFS improvement in the adjuvant non-small cell lung cancer setting after platinum-based chemotherapy. And the adjuvant atezo following complete resection and adjuvant chemotherapy showed a significant statistically significant DFS in TC more than or equal to 1 with hazard ratio of 0.66. Empower 010 will continue for DFS and OS analyses, and the safety profile of atezolizumab was consistent with prior experience of atezolizumab monotherapy across indications and lines of therapy. Atezolizumab may be considered a practice-changing adjuvant treatment options for patients with PD-L1 TC1 more than 1 or equal to 1 stage 2 to 3A. So then neoadjuvant versus adjuvant. Is lung cancer a new site where we are going to see more movement towards neoadjuvant? We have, I think that it's too early to know this answer because we have lots of ongoing trials in the neoadjuvant setting and also in the adjuvant setting. We have immunotherapy trials and targeted therapy trials. And the other question actually also, I think with if we are going to move to the neoadjuvant targeted or immunotherapy, then having a comprehensive genomic testing upfront is really important to guide our treatment plan. I think the field of lung cancer is really getting more exciting, and we'll see hopefully in the future what will be actually the best approach. So for the preoperative systemic therapy, of course, there is a pros and cons for each treatment option. And for the neoadjuvant treatment, it is treating the micrometastases early, can improve resectability. It can also cause downstaging, better compliance, better treatment tolerance, and insights into disease biology, as well as facilitates translational studies. On the other hand, it can actually, toxicity can prevent surgery, or progression can prevent surgery as well. We have many ongoing phase 3 neoadjuvant trials, and today I will be talking about the Checkmate 816. So Checkmate 816 was first presented in the AACR, and then we had more updates in the ASCO in terms of the surgical outcome. And in this trial, their eligibility criteria was newly diagnosed resectable stage 1B to 3A non-small cell lung cancer with excellent performance status. EGFR and ALK were not included, and they stratified patients based on stage, PD-L1 status, and sex, and then they randomized them to nivo plus chemo versus chemo, and then they did radiologic restaging and surgery within 6 weeks post-treatment, and then an optional adjuvant chemo plus or minus radiation. The primary endpoint was PCR and EFS, and a secondary endpoint MPR and OS. And baseline characteristics were equivalent, stage 3A around 60%. And when they presented the initial result, the PCR in the ITT population, it was 24 in the chemo plus immuno versus 2.2 in the chemo arm. And the NPR is 36.9 versus 8.9% in the chemo arm. Then they also tested if the circulating tumor DNA clearance and the association with pathologic response, and they found that the circulating tumor DNA clearance rate was higher in the nivo plus chemo, and also there was a relation between this and the PCR. When they looked at the subgroup analysis, majority gained benefit from the combo, and then also the overall response rate was higher in the nivo plus chemo arm. And when they looked at toxicity, the treatment combination was generally speaking tolerable. Then it was very interesting to see the surgical outcome in the last ASCO. So more patients actually received surgery in the chemo plus immune arm, 83% versus 75%. And also the median duration of surgery was lower in the combination arm. And the conclusion from the Checkmate 816 is PCR benefit consistent across analyzed subgroups. NPR and OR also improved. Data is immature for the co-primary endpoint EFS, and the exploratory subset analysis observed that the circulating tumor DNA clearance more frequent with nivo plus chemo versus chemo alone and associated with PCR. Neoadjuvant nivo plus chemo demonstrated a tolerable safety profile without adversely affecting feasibility of surgery. And we know now actually there is more benefit from it, the surgical outcome point of view from the ASCO. And the Checkmate 816 is the first phase 3 trial demonstrating benefit of neoadjuvant immunotherapy with chemo for resectable non-small cell lung cancer. And so far, we don't have an FDA approval for either this combination or the atezo in the adjuvant setting. And by this, I conclude my presentation. Thank you.
Thank you, Samah. Thank you, Samah. This is very comprehensive talk about the adjuvant immunotherapy. I think now the floor is open for the questions. I don't have question here in question and answer box, but for the attendees, anybody have a question? So I have a question to Dr. Hamid. Now we are facing financial constraint in most of the hospitals. In patients who are having ALK mutation, not all the hospitals are having alectinib as a first line. Maybe crizotinib as first line sometimes, or if alectinib using the first line, it will not be easy. It won't be easy to get the second line lorlatinib. What will be your next choice for your second line? Is it immuno or chemotherapy?
You mean if patient treated with the crizotinib as a first line,
or alectinib,
so
and you don't have the other medication, so you are left with only chemo or immune. So one line of ALK inhibitor is found in your hospital.
I mean, if you have one line and the second line, I think better to try your best to get a second line instead of going to the chemotherapy, if possible. You try your best. Maybe you will succeed. But I mean, if you don't have any other second line, then I think you will go to the chemotherapy to give chemotherapy alone, and maybe the immunotherapy later as after failure on chemotherapy. But I prefer to try your best to get a second line ALK inhibitor if possible, better than to give chemotherapy or immunotherapy.
Yeah, of course, this would be the best. Any other question? Dr. Samah, did you start using the immunotherapy in the adjuvant setting?
Not yet. We are actually waiting for the approval, and also I really want to see more data about the quality of life data, because immunotherapy toxicity can be actually longer than chemotherapy or TKIs. So I will be interested to see this before actually starting using atezo as in the adjuvant setting.
Okay, thank you. Any question? I think by this we can conclude the last session for today. Thank you very much. I would like to thank the attendees and the speaker for their excellent participation. See you tomorrow at 9:30, inshallah. Thank you very much.
Thank you all. Thank you.
Thank you.